Good evening, everybody. Today I'll be talking about aortic arch anomalies. First, briefly about the development of the aorta and its arches. The heart is seen in the form of two endothelial heart tubes around the 18th day of fetal life. Each heart tube fuses, forms a single tube, which later forms different dilatations like sinus, venosus, atrium, ventricle, and bulbous cord. This and begins to beat by 22nd day. This is a fused heart showing different dilatation. This is the venous end. This is the arterial end. That is the bulbous parties, which forms the conus proximally and truncus distally. This is the primitive ventricle, atrium, and sinus venosus. Bulbous cord is represent the arterial end of the tube. The proximal part of it is conus and the distal is truncus arteriosus. Right and left primitive aorta connected to the endothelial tube by paired system of aortic arches. The first pair of the aortic arch is formed between 22nd and 24th day. They regresses completely except for a small remnant of the maxillary arteries in the adults. The dorsal aorta remain separate in the region of the aortic arch, that is in the upper part, but during the 4th week they fuse together from the T4 segment downwards to the level of 4th lumbar segment and form the midline dorsal aorta. Between days 26 and 29, the aortic arches 2nd, 3rd, 4th, and 6th develop by vasculogenesis and angiogenesis within their respective pharyngeal arches. On day 28, the 3rd and 4th aortic arches form, and on day 29, the 6th arch forms. The 2nd arch regresses except for a small remnant of the stapedial artery. The 3rd arch arteries give rise to the carotid arteries. By the 7th week, the right dorsal aorta loses its connection with the fused midline dorsal aorta and the right 6th arch and joins with the 7th cervical intersegmental artery, which develops within the right upper limb bud. The left 4th aortic arch retains its connection with the fused dorsal aorta, and along with the aortic sac, it becomes the aortic arch and most cranial portion of the descending thoracic aorta. The remainder of the descending aorta is derived from the level of 4th thoracic vertebra, is derived from the fused dorsal aorta. The left 7th intersegmental artery gives rise to the left subclavian artery, supplying the left upper extremity. Right and left 6th arches arise from the proximal end of the aortic sac. By the 7th week, the distal connection of the right 6th arch with the right dorsal aorta disappears and forms part of the pulmonary artery. The left 6th arch forms part of the ductus arteriosus and left pulmonary artery. This is a picture showing the aortic sac, two dorsal aorta, fused in the midline. These are the 6 arches connecting the heart tube This picture shows the derivatives of the third arch, which form the common carotid arteries. The right fourth aortic arch remodels and becomes the proximal part of the right subclavian artery. This part of the right aortic arch has disappeared. The left fourth arch forms part of the aortic arch, marked in blue color. The right sixth aortic arch forms part of the right pulmonary artery. The left sixth aortic arch forms part of the left pulmonary artery and the ductus arteriosus. The right seventh segmental artery forms the distal part of the right subclavian artery, supplying the right upper limb. The left seventh segmental artery forms the entire left subclavian artery. The right dorsal aorta regresses except for a portion that forms part of the right subclavian artery. The left dorsal aorta will develop into a descending thoracic aorta. So, in brief, the first arch vessels regresses except for part of the maxillary arteries. Second arch also disappears except for a part of the stapedial artery. The third arch on both sides form the common carotid arteries and its branches. The fourth arch on the left side forms part of the aortic arch and part of the right subclavian artery on the right side. The fifth arch completely disappears. The sixth arch forms part of the left pulmonary artery and ductus arteriosus on the left and right pulmonary artery on the right. The seventh segmental artery gives rise to left subclavian artery on the left and part of the right subclavian artery. The dorsal aorta on the left continues as descending thoracic aorta, and on the right side it disappears except for a part of the right subclavian artery. So the arch of the aorta is derived the proximal part from the aortic sac, the middle segment from the left aortic arch, left fourth arch, and the distal segment from the fused dorsal aorta and left dorsal aorta. The subclavian artery on the right side is formed by right fourth arch, part of the right dorsal aorta, and seventh intersegmental artery. Fourth arch, part of the descending thoracic aorta, and seventh intersegmental artery. The left subclavian artery is entirely derived from the left seventh intersegmental artery. The anomalies of the aortic arch are conceptualized as variations in regressions of different segments. Briefly about the anomalies, the anomalous right subclavian artery was first described by Arnold in 1735. The double aortic arch was described by Hummel in 1737. Right aortic arch by Perotti Angeletti in 1763. The interrupted aortic arch by Spiegel in 1788. 1787, Bayford coined the term dysphagia lusoria, that's the dysphagia caused by vascular ring. The anatomical classification of arch anomalies are: there may be abnormalities of branching, there may be abnormalities of arch position, that is, it may be cervical arch or right-sided arch. There may be supernumerary arches like double aortic arch and persistent fifth arch, interruption of the aortic arch, and anomalous origin of the pulmonary artery branch. Clinically, they are classified as vascular rings. There is an anomaly in which trachea and esophagus are surrounded by vascular structures. Non-ring vascular compression of trachea, bronchi, or esophagus. Non-compressive arch malformation and duct-dependent arch anomalies. It is important to know the sideness of the aortic arch. Left and right aortic arch definitions is based on the bronchus, which is crossed by the arch. Normally, the aortic arch crosses the left main bronchus at the level of fifth E5 vertebra, and the branching general rule is that the first arch vessel contains a carotid artery contralateral to the aortic arch. The importance of knowing the sideness of the aortic arch helps in putting BT shunt and in repair of esophageal atresia. Some of the normal variants of the left aortic arch are the common brachiocephalic trunk, that is, the right innominate and the left common carotid arteries arise from a single trunk, seen in about 10% of normal population, and possibly there may be compression of the trachea. Next is the separate origin of the left vertebral artery, seen in about 10% of the population, and usually it arises proximal to the left subclavian artery. The abnormalities of branching are on that few types: aberrant right subclavian artery, innominate artery compression syndrome, right arch mirror branch, right arch with aberrant left subclavian artery, double aortic arch, double arch with athletic segment, aberrant right subclavian artery. This is the most common anomaly, seen in about 0.5 to 2% of population. It is not a true ring, and it's usually asymptomatic. Sometimes the dilated subclavian artery compresses the esophagus posteriorly and can cause dysphagia. It's called dysphagia lusoria, and it's seen in about 38% of Down syndrome with congenital heart disease. This is a diagram showing the development of the aberrant right subclavian artery. If there is abnormal obliteration of the right aortic arch, with abnormal retention of the right dorsal aorta, and the subclavian artery crossing behind the esophagus. This is the right common carotid, left common carotid, left subclavian and right subclavian artery. It is alternatively known as Lusorian artery. The aberrant right subclavian artery frequently arises from a dilated segment of the proximal descending thoracic aorta called coronal diverticulum. On barium study, we may see a small filling defect on the posterior aspect of the esophagus slanting upwards. On an angiography, there will be first filling of the right carotid artery and the aortic root injection. This is the radiograph, barium swallow, showing posterior indentation of the esophagus on barium swallow. This is another example showing compression of the esophagus with dilated proximal segment causing dysphagia. This is the CT showing aberrant right subclavian artery showing the trachea and the esophagus. This is the coronal MPR showing the aberrant right subclavian artery course. This image shows thrombosed aneurysm of the right subclavian artery. Aberrant right subclavian artery arises as the fourth branch after the left subclavian artery. It then hooks back to reach the right side. Its relationship to the esophagus is variable. 80% of the cases it is posterior to the esophagus, 15% between the esophagus and trachea, and 5% anterior to the trachea. Next is innominate artery compression syndrome. Children, the innominate artery is located more to the left and may compress the trachea anteriorly. The trachea showing the compression of the innominate artery. This is the MPR showing indentation on the trachea. This is one of the most common cause of airway compression by vascular swelling. Usually presents with expiratory stridor, cough, recurrent infections, and occasionally apnea. This is a scanogram showing anterior compression of the trachea. And this is a CT showing the innominate artery compressing the trachea with narrowing, luminal narrowing. The compression of the trachea is on the right anterior side and at the level of the thoracic inlet. This compression decreases with age and the patient will outgrow it. Next is right arch mirror image. Usually asymptomatic and associated with congenital heart disease in 98%, and most commonly is a tetralogy of Fowler. It is asymptomatic because there is no obstructing vein. There are usually three types: right-sided aortic arch with mirror image branching. Type 2 is right-sided aortic arch with aberrant left subclavian artery, and third one is right-sided aortic arch with isolated left subclavian artery. The developmental embryology of the right aortic arch is abnormal persistence of the right dorsal aortic arch and regression of the left dorsal aortic arch. There is abnormal obliteration of the left arch with persistent right arch, forming the right arch. This is the diagram showing the right arch with the mirror image branches. Type 1, that is the right-sided aortic arch with the mirror image branching. This occurs from the interruption of the dorsal segment of the left arch between the left subclavian artery and the left descending aorta. That is this part, distal to the left subclavian artery. Usually associated with cyanotic congenital heart diseases, which include most commonly the tetralogy of Fowler. Others may include truncus arteriosus, tricuspid atresia, and transposition of great arteries. Type 2 with aberrant left subclavian artery. This is the most common, accounting for about 40% of all right-sided arches, and usually associated with humerus diverticulum. Usually it occurs from interruption of the dorsal segment of the left arch between the left common carotid and left subclavian arteries with regression of the right ductus arteriosus. Rarely produces symptoms. Rarely it can cause esophageal or tracheal compression. and rarely associated with other cardiac abnormalities. Type 3 with isolation of the left subclavian artery is the more straight type. Because from introduction of the aortic left arch at two levels, one between the left common carotid and left subclavian arteries, and the other distal to the left ductus arteriosus. May be associated with congenital subclavian steal syndrome and vertebrobasilar insufficiency. Radiographic features. These are the two different patients showing absence of arch on the left side. The arch is on the right side. Later on the left radiograph. There is compression of the trachea. And right side arch in highlighting and projecting as a mass in the right paratracheal region. This is as a mass in the right paratracheal region. Cross-sectional imaging of the CT and MRI are more helpful and helps in diagnosing the type of the aortic arch and its branch configuration. This is the CT showing the right side aortic arch, and this is a MRA showing right aortic arch with 4 vessels. This is the right aortic arch with aberrant left subclavian artery, and this is the dilated segment known as coronary diverticulum. This is another case of right aortic arch with left subclavian artery going anterior to the trachea and esophagus. There is no vascular ring here. This is another image showing the right arch with aberrant left subclavian artery. The aortic arch is on the right side. The left subclavian artery aberrant going posterior to the trachea. This is the right aortic arch with aberrant left subclavian artery going posterior to trachea and esophagus. The right aortic arch with an aberrant left subclavian artery is an obstructing anomaly. The first branch of the aorta is the left common carotid, followed by the right subclavian artery and the right common carotid artery. The ligamentum of the ductus arteriosus between the aortic arch and the level of the left subclavian artery and the left pulmonary artery completes the ring. This is another image showing right aortic arch with aberrant left subclavian artery crossing posterior to trachea and esophagus. The NPR image showing indentation of the trachea. Next is the double aortic arch. This is a complete vascular ring encircles the esophagus and trachea. Most commonly there will be 4 vessels signed. This is the most common vascular ring anomaly. It is rarely associated with congenital heart disease. The vascular ring produces tracheal and/or esophageal compression. This is caused by persistence of the right and left 4 bronchial arches. It passes on both sides of the trachea and joins posteriorly behind the esophagus. The right arch is larger and higher than the left arch, which is smaller and lower. There is also another variant called double arch with arteritic segment. In this, the left arch is very small and has a small arteritic posterior segment. Still, there will be 4 vessels. In this, there will be 2 brachiocephalic vessels on each side. The arteritic segment persists as a fibrous cord tethering the anterior left arch to the descending thoracic aorta. This is the diagram showing the double arch. This is persistent of the right and left both arches. Usually this right arch disappears, but persists into the right fourth arch gives rise to double arch. This is the diagram showing the double arch completing a vascular ring with compression of the trachea and esophagus. This is the four vessel sign: right, left, common carotid, and subclavian arteries on each side. This is a schematic diagram showing the right arch higher and larger than the left arch, which is smaller and lower, and four vessels arising from the arch, called four vessel sign. The same radiogram in a 6-month-old child presented with stridor and cough. The trachea is slightly deviated to the left with mild compression and mass effect on the trachea. There is apparent widening of the mediastinum, superior mediastinum. This is another radiograph showing the double aortic arch. This is left arch. This is the right arch higher, appears as a paratracheal mass. The other differentials include tumor, adenopathy, or vessel like right arch, dilated asparagus vein, or dilated aberrant right subclavian artery. This is the compression of trachea and lateral radiograph. This is the barium swallow in the patient with a double aortic arch, showing indentation on the right side as well as the left side. The other patient, the lateral radiograph is called S-shaped barium histogram because of compression on two sides. This is the frontal chest radiograph showing indentation on the right side, esophagus on the right side, as well as on the left side, giving that S-shaped esophagram. On lateral view, there is anterior displacement of the esophagus and trachea. The trachea and the esophagus both increase distance here. The axial CT with horizontal images showing four vessels, double arch, a complete vascular ring. The left arch is smaller, the right arch is bigger. The MPR and volume rendered images, the right and left arches with thickle indentation. The other type is the double arch with aortic segment. Part of the left arch is very small, and the part of the left arch is very small. And however, in this still there will be four vessel sign. You can be confused for right aortic arch. This is another image showing aortic segment, right double arch with aortic segment. The distal part of the left arch is smaller here. This is a narrow segment, better seen now. This common image showing aortic segment of the left arch. Next is the coarctation of aorta. There are two types, predictal and postdictal. The predictal type, the coarctation is proximal to the ductus arteriosus. This is less common. Blood flow to the aorta distal to the narrowing depends on the patency of the ductus arteriosus, and hence its closure can be life-threatening. Collateral circulation develops mainly by branches from the subclavian arteries, capillary, internal thoracic and intercostal arteries. It's associated with notching of the ribs and There will be hypertension in the upper extremity with weak pulses in the lower extremities. This is the post-ductal type of coarctation, showing coarctation distal to the ductus arteriosus, bring multiple collaterals, intercostal arteries, and there will be increased pressure in the upper extremities, proximal to the coarctation, vessels supplied by the proximal to the coarctation, and reduced pressure in the lower extremities distal to the coarctation. Post-ductal type is the most common, usually distal to the ductus arteriosus. The ductus usually remain open to communicate with the pulmonary artery. The blood flow to the lower body can be impaired even with the presence of open ductus arteriosus. The axial CT image in a child showing the coarctation of the aorta, where the ascending aorta there is a discrepancy in the size of the ascending and descending thoracic aorta, and this is a reformed image showing the narrow segment. This is the axial image and reconstructed image. Here the internal mammary arteries are dilated. It is difficult to make diagnosis on this axial image, so the reformat is better, showing the coarctation and the multiple collaterals, intercostal collaterals here. The MR picture showing the coarctation, the post-ductal type, the narrow segment here. This is a picture showing multiple intercostal collaterals, typically occur between 38 ribs, causing notching of the ribs. Next is persistent of the fifth arch. Was first reported by Van Troy in 1969. It's a rare anomaly. It is a double lumen aortic arch in which both arches appear on same side of the aorta, same side of the tracheus. Usually two common types have been described. The way vessel beneath the normal arch is fourth arch that extends from innominate to take off as left subclavian artery. The double lumen aortic arch with atresia of the superior arch with patent inferior arch. This there will be common origin of the all brachiocephalic vessels from the ascending aorta. The type 1 double lumen aortic arch with both lumen patent is the normal arch, fourth arch. This is the fifth arch, usually associated with major cardiac anomalies. This is the type 2. This is interruption of the fourth arch, not continuing as descending thoracic aorta. The fifth is continuing as descending thoracic aorta. In this, there is a common origin of all the brachiocephalic from the ascending aorta, can be associated with coarctation of the aorta. Diagnosis is there is a presence of subway vessel beneath the normal arch. In case of atresia of the superior arch, all the bronchial vessels, cephalic arch arises from the common ascending aorta. That is common origin of all four vessels from the ascending aorta. This is the diagram, schematic diagram showing the persistent fifth arch. The fourth arch, this is the fifth arch. This is a subway vessel. This is the MR image showing persistent fifth arch. This is a normal fourth arch, fourth and fifth arches. Next is interrupted aortic arch, defined as complete separation of the ascending and descending aorta. Gloria and Patton classified it into three types. I say there is interruption distal to the subclavian artery. Type B, interruption between the common carotid. Type C is interruption between the carotid. This is a diagram showing the normal arch. The type A, there is disruption distal to the left subclavian artery. This is the left subclavian artery, and there is disruption distal to the left subclavian artery. The type B, there is interruption between the left common carotid and left subclavian artery. And type C, there is interruption between the common carotid, that is two brachiocephalic arteries. The right, this is the left brachiocephalic arteries and the branches. The type A is due to involution of both dorsal aorta distal to the fourth arch and proximal to persistent sixth arch. Type B is due to involution of the fourth arch and one dorsal aorta between fourth and sixth arches. Type C is involution of one of the limbs of the trunco-aortic sac. This is the chest radiograph. It's child showing prominent soft tissue density in the left paratracheal region. And this is the coronal MR image showing multiple collaterals, the paravertebral region. And this is the candy cane section showing disruption of the aortic arch in the aortic aorta and descending thoracic aorta. Thank you. The remainder of the anomalies will be built in next class. Thank you.